Welcome. Good morning, good afternoon, good evening, wherever you're joining us from. My name is Steve Van Warmer. I'm the president of PAH Global Association. We are very excited to have you with us here today on our On Air with PAH summer series of webinars that explores the remarkable evolution of pulmonary arterial hypertension from its earliest challenges to today's breakthroughs and the promising future of research and care. Whether you're a patient, a caregiver, a healthcare professional, researcher, or patient advocate, these live conversations offer valuable insight into how far the PH community has come and where it is headed to next. And we are thrilled today to have Dr. Valerie McLaughlin with us to give us a detailed history of one of those first successfully targeted pathways, prostacyclin. Dr. McLaughlin is a Kim A. Eagle, MD, endowed professor of cardiovascular medicine and the director of the pulmonary hypertension program at the University of Michigan in Ann Arbor. Internationally recognized as one of the world's leading experts in pulmonary arterial hypertension, Dr. McLaughlin has been instrumental in advancing the understanding, diagnosis, and treatment of pulmonary vascular disease through her decades of groundbreaking clinical research. A principal investigator in numerous landmark PAH clinical trials, Dr. McLaughlin has helped shape modern treatment strategies and international clinical guidelines for PH. She is a respected leader in the field and serves on the steering committee of the 8th World Symposium on Pulmonary Hypertension, where experts from around the world collaborate to advance the future of PH diagnosis, classification, and treatment. So following her presentation this morning, we're going to have time for some of your questions. So please, throughout her lecture, take a moment. There's a tab that says Q&A at the bottom of your screen or in the chat function. If you have some questions for Dr. McLaughlin, she can answer those at the end of her lecture. And finally, a very big thank you to our webinar sponsors today, Merck and Liquidia. Through the strategic use of innovative technology and compelling storytelling, your support helps PH Aware amplify the voices and experiences of patients worldwide, fostering a more informed and connected worldwide community. So without further ado, welcome to the birth of modern PAH therapy. Dr. McLaughlin, thank you so much for being with us here today.
Oh, Steve, it's my pleasure. And thanks everyone for attending. And you've given me a topic that is near and dear to my heart, and that has to do with the prostacyclin. So is it okay if I share my screen now and we can?
Yes, I defer to you.
All right. Can you see that?
Yes, you're great. You're good.
Okay, great. So I'm so excited to be part of this summer webinar series, and I'm even more excited to have the topic of prostacyclins, the history of prostacyclins. This is actually a lecture that I've interestingly enough been asked to do several times this year. So I'm happy to share it with you. These are my conflicts as they relate to the area of pulmonary hypertension. And kind of the outline, I'm going to talk a little bit about the history of the prostacyclin pathway and its development. As Steve mentioned, we have so many therapies now, and I'm going to kind of make a couple highlights on the unique contributions that prostacyclin trials have made to clinical trial development in pulmonary hypertension. I am going to talk a little bit about the evolution of the treatment algorithms. As Steve also highlighted, there are so many new therapies. We're learning so much, and these can impact some of the ways that we use prostacyclin. So I'll highlight that, and I'll talk a little bit about what I think the role of the prostacyclin pathway agents is today in 2026. So it's hard to believe it's been 30 years. In fact, this year is the 30-year anniversary of that first seminal publication of IV epoprostenol in PAH. And there have been ups and downs, and it's been a really exciting ride that I've been so privileged to experience. So I don't know if many of you know sort of the history of the discovery of prostacyclin. It was discovered in 1976 by Sir John Vane, who really has done a lot of remarkable work, and there's still a conference every year in London that occurs in his honor, branded by his name, is all about prostacyclin science. And he shared the Nobel Prize for Medicine in 1984 for the discovery of prostacyclin and the analysis of its biological effects and functions. Now, he was based in the UK and, really was instrumental in trying to understand where prostacyclin could fall in the treatment of medical diseases. There was some initial work on peripheral vascular disease, but he started working with Tim Higginbottom, who's a very brilliant UK physician, and then aligned with with Wellcome and developed development of products with the Wellcome Foundation in the UK. In the beginning, Flolan was born, and so this was what was approved in 1995. And just as kind of another historical aspect, 1995 was the year I finished my fellowship, and I was recruited out of fellowship to work with Stuart Rich at the University of Illinois. And at that time, 1995, there were maybe 10 centers, and I started working with Stuart. He really recruited me to do other things. I was an echocardiographer, starting to work on fast CT. But after I was there about 6 months, he invited me to work on pulmonary hypertension with him. And the timing was really opportune. It was like right when Flolan got FDA approved, and he clearly was going to need help because now there was this therapy. And so he took me on and was the best mentor anyone could ever have. And so I actually feel like I got in on the prostacyclin experience, really at the beginning. And this is an incomplete list, and it obviously extends a little bit more now, which we'll talk about later. But this is a sort of a summary of trials that have looked at the prostacyclin pathway in one way or another, and it really started with IV epoprostenol, but then, as you all know, we have subcutaneous versions, we have inhaled versions, we have oral versions, we have versions that are not prostacyclin replacements, but prostacyclin agonists. And look at all of these trials that have been done in the past 30 years with prostacyclins. It's really, really impressive. So let's start with the beginning, and that is IV epoprostenol. And this was the study that led to the FDA approval of IV epoprostenol. And every time I look at this, it just blows my mind because the FDA approved this drug based on a 41 patient study, I'm sorry, an 81 patient study, 41 in the EPO group, 40 in conventional therapy. It was randomized, but it was not placebo controlled because it was really not considered ethical to put an indwelling central venous catheter in and infuse placebo. That was considered risk. The patients enrolled, so this is 1995. So in the 1990s, we were seeing mostly younger patients who had what was then called primary pulmonary hypertension, what we now call idiopathic pulmonary arterial hypertension. And of course, there was no other therapy. So these patients were all treatment naive. This study was a positive study. The improvement in the primary endpoint was a 6-minute hall walk, but there were also improvements in important secondary endpoints, including hemodynamics. And there was an improvement in survival, which is what you see here. 8 of the 81 patients in this trial died over the 12-week period, all of whom were randomized to the conventional therapy group. And even today, this remains the only clinical trial in which there was a survival benefit in the context of a randomized controlled trial. So it was a very effective therapy, and it then became commercially available initially just for patients with idiopathic, or what was then called primary pulmonary hypertension. Um, Being with Stuart at that time, being at one of the centers at that time where we had a pretty large patient population, and now that there was something approved, we had many patients come to us to get started on this therapy, and we wrote up our clinical experience first in this paper that was published in the New England Journal. And one of the main messages of this paper is, or was, that IV epoprostenol does something beyond acute vasodilatation. So on this figure, you see the pulmonary vascular resistance at baseline in these patients. You then see their pulmonary vascular resistance after an adenosine challenge, so the acute vasoreactivity testing. So this is intended to kind of see what you get with vasodilatation. But then after a year of epoprostenol, pretty much in all but one person, you see even a lower pulmonary vascular resistance. So at that time, we opined that, yes, it's probably a vasodilator, but it probably does something else. It probably helps remodel the pulmonary vasculature in some way. We then kind of published our pretty large experience of treatment with epoprostenol, so kind of an observational registry. And what you see here on the left is the experience that Stuart and I had in Chicago, where we showed the survival of our patients being treated with IV epoprostenol compared to what would be expected based on their hemodynamics in the NIH registry. And on the right, you see a paper that was published from Olivier Sitbon in the French group, actually the very same month. I think this was October of 2022. His was in JACC, mine was in CIRC, but they looked at the survival of epoprostenol compared to historical controls in the French registry. And these papers, if you read them, they're essentially the exact same papers. What we were describing in our patients in Chicago was exactly what they were describing in their patients in Paris, in France. The improvements in symptoms, the improvements in exercise tolerance, the improvements in hemodynamics, and what looked like a survival benefit compared to either the NIH registry or the historical controls. And so it always makes you feel good when you really see the same results in two different patient populations in two different centers. And I think, at this time, so we're now 2.5 decades ago, in the early 2000s, I think we had a really good feel for what IV epoprostenol could do. It's a life-saving therapy. Now, even though it's a life-saving therapy, it's a highly burdensome therapy. And if there are any patients in the audience that are on pumps, this very well. It's a huge burden to patients. They're required to carry the pump 24/7. They need to prepare the medications, infuse it, operate the pump. They always have to be aware of taking care of their pumps and their catheters so that it doesn't get dislodged, because an abrupt discontinuation of the infusion can be life-threatening. Of course, there's risk of infection. So, while we were at that time, and we still are so thankful for what that therapy has given us and given to the patients. It's really been a life-saving therapy. It's obviously a very complex therapy that has some downsides as well. And you always have to balance side effects of medications and symptoms of disease. So the next advancement in prostacyclin therapy for pulmonary hypertension was with subcutaneous treprostinil. And I really want to highlight this development program as I think it started, was the beginning of the worldwide network that we have built in the space of pulmonary hypertension. I never had any idea when I started doing this that I would make friends and colleagues and work with people, become good colleagues with people all around the world as we search together for new therapies, as we work to study medications and advance therapies for pulmonary hypertension. So this is a list of the study sites that were in the what was referred to as 0405, but this is essentially the subcutaneous treprostinil clinical trial. And this was the beginning of it. There are many more sites that are involved now, but one of the things that I'm very proud of for our community, and as we think about the history and the evolution, is how we have built a network of investigators, of clinicians, really working together to study therapies and advance science. And that drug was FDA approved. There was an improvement in hall walk in the clinical trial that was dose dependent. We needed to learn how to use this drug because one of the drawbacks of this drug is that it causes pain and redness at the site of the subcutaneous infusion in many patients. And it took us a while to understand how to dose it and what to push through. And so even though it is an effective therapy, and we still use this, we have patients on subcutaneous treprostinil as well. The infusion site pain occurs in a lot of patients, and in some patients cannot manage the discomfort, and it's not the right medications for them. Of course, there's the pumps and malfunctions, and you have to be aware of that as well as the other prostacyclin-like side effects. So we always have to balance the treatment burden. We always need to think about shared decision making and try to set up our patients for success when they need these complex therapies. While treprostinil was originally studied as a subcutaneous form, it was subsequently approved as an intravenous form as well, based on bioequivalence. And so when we say parenteral therapy, what we're really referring to is epoprostenol, which is only IV, and there are a couple different versions of that. And then treprostinil, which can be either IV or subcutaneous. Then we go into inhaled therapies, and inhaled iloprost was really studied primarily in Europe. It was studied in the AIR study shown here that was, it studied a population in this that include both group 1 PAH, but there was also CTEPH in this group as well, not amenable to surgery. There was an improvement in the composite endpoints that it took into account hall walk, functional class, and absence of worsening. Iloprost is a tough drug to use. It's an inhalation that you have to do 6 to 9 times per day, which is pretty burdensome. Of course a pump is burdensome, but also getting out a device and doing an inhalation treatment that takes maybe 20 minutes, 6 to 9 times a day, is pretty burdensome as well. And whenever you inhale something, cough is one of the main side effects. So that was a great idea. And then the next thing that came along was treprostinil, which was studied as an inhaled version as well. And so the TRIUMPH study looked at the addition of inhaled treprostinil, which was 4 times a day. So, still kind of burdensome. That's a lot of times a day to remember to take your medication, but much better than 6 to 9 times a day. And the inhaled treprostinil in this study was looked at on top of oral therapy either with bosentan or sildenafil, which was the standard. Those were the oral therapies available at that time. And there was an improvement in the primary endpoint of 6-minute hall walk, which led to the approval of inhaled treprostinil for pulmonary arterial hypertension at about 2010. So now we have IV, sub-Q, and inhaled therapies for pulmonary hypertension. I do want to say just an additional note about inhaled treprostinil as well, because this is now the first time we have had one of the drugs that is approved for group 1 PAH to be approved for group 3 pulmonary hypertension. And that was on the basis of the INCREASE study, which looked at inhaled treprostinil in patients with group 3 pulmonary hypertension due to interstitial lung disease. And there was an improvement in the primary endpoint of 6-minute hall walk distance there, and also some other secondary endpoints, including NT-proBNP and clinical worsening. So this is a great example of how we're translating some of the drug development that we've done in group 1 to other groups. So here specifically group 3. And just in terms of what's happened in pulmonary hypertension, I really credit this study with generating a lot of enthusiasm for additional therapies for patients with group 3 pulmonary hypertension due to interstitial lung disease. But again, there's no perfect therapy oftentimes in any disease. And while they're less invasive than IV and sub-Q, inhaled therapies can be inconvenient for patients, 4 times a day or 6 to 9 times a day. That's still a lot, and it still interrupts their day. And of course, cough is a common symptom from that. So now we move on to oral therapies, and everybody wants a pill. That's the easiest thing. And Bariprost is one of the first oral therapies that was studied. Bariprost is an oral prostacyclin analog. It is not available in the US because it never met regulatory approval. This was the US trial. It was referred to as the Alphabet trial. It was a year-long trial. And you can see there was a bit of an improvement in hall walk early on at the 3 to 6 month time frame, but it really didn't last for the 12 months of the study. And so regulatory approval in the US was not pursued, although there are other countries in the world where Bariprost is available. And then our old friend treprostinil gets studied as well in the oral version. And this received regulatory approval in the US based on the Freedom M trial. So this development program looked at oral treprostinil on top of background therapy, because at this point in the early 2010s, of course, there were endothelin receptor antagonists as well as PDE5 inhibitors available, and patients were started on those therapies. The Freedom M trial looked at oral treprostinil in patients not on any other background therapies. It was essentially treprostinil monotherapy. And there was an improvement in the 6-minute hall walk of about in the mid-20s, and that led to the FDA approval of oral treprostinil in the US. The 2 studies with oral treprostinil on background therapy are listed here, Freedom C and Freedom C2. And on top of ERA and or PDE5 inhibitors, there was not a statistically significant in the primary endpoint of 6-minute hall walk or either of the secondary endpoints of time to clinical worsening or functional class improvement. So that's not the end of the treprostinil story. We will come back to it, but it received regulatory approval in the US initially as just monotherapy, based on the monotherapy study. Now, I have said I kind of want to highlight some of the unique contributions of clinical trial design that we've seen in the prostacyclin pathway. And one of those is looking at the time to clinical worsening endpoint. So up until now, we've talked about trials where it's pretty much 6-minute hall walk that is the primary endpoint. And 6-minute hall walk is it's a good endpoint. It's, how patients can function is measured by the 6-minute hall walk. They want to feel better. They want to do more. It's relevant. There are standards for what is a minimally effective change in 6-minute hall walk that correlates with a change in quality of life for the patient. The FDA will accept a 6-minute hall walk as a primary endpoint. But along about late 2010s, late 2000s, early 2010s, the community, that the PH community was saying, we need to do more than hall walk. We can make our patients feel better. We have therapies to do that, but we want to see our patients do better over the long term. We want to see less death, less hospitalization, less lung transplantation, less need for pump therapy. And so a number of trials that looked at composite endpoints of time to morbidity or mortality started being done. And the Griffon trial is one of those. And in fact, this trial still to date is the largest ever trial of pulmonary arterial hypertension, with over 1,000 patients. So the prostacyclin class has the smallest ever RCT that led to regulatory approval with 81 patients with IV epoprostenol, and the largest ever trial, I think this was 1,036 in the Griffon trial, and it looked at this composite endpoint of time to clinical worsening. And there was an improvement in that composite endpoint of time to clinical worsening in patients treated with selexipag versus placebo. And this led to the regulatory approval of the prostacyclin receptor agonist selexipag in 2015. Now, we've talked a little bit about oral treprostinil, didn't hit on 6-minute hall walk, but then they subsequently did what's called the Freedom EV study that also looked at longer term events, looked at clinical worsening in patients who are on background monotherapy. So this one you could be either on PD5 SGC or on an ERA. And so this study demonstrated a statistically significant improvement in freedom from clinical worsening. And so now we have more data with oral treprostinil in combination with background ERA or PD5/SGC. So that's all great. Now we move to the most recent prostacyclin studied in a clinical trial, and that is ralinepag. And this is a prostacyclin receptor agonist that is a little bit longer lasting. It's got a longer half-life, so it's only once a day compared to selexipag. And this was studied, again, a composite endpoint of time to clinical worsening, disease progression. And this was just reported out as a positive trial this year with a statistically significant 55% reduction in that composite endpoint. And I think there are also a couple notable things in this trial that I want to highlight. It's actually the first randomized controlled trial that included patients with the newer definition of pulmonary arterial hypertension. So it allowed patients with that mean PA pressure in the range of 20 to 25 to be included. It was also primarily done in a low risk population on background oral therapy. So I think this is an important contribution to the science, to the clinical trials that we have. Of course, this was just published, and the regulatory package for this is still being put together, so it's not yet commercially approved, but hopefully we will be able to use this drug commercially after approval in the not too distant future. So those are the most of the randomized controlled trials that I want to highlight. And now let's go into a little bit of how the treatment algorithms have changed over the years. And I could show you algorithms, pretty much every year or two from one publication or another, but I won't do that. I'll just go back to one of the earliest ones that I could find. And this was the treatment algorithm from the World Symposium that happened in Venice in 2003. It was a lot different then. So we were looking only at patients with functional class 3 and 4 because none of the trials included patients with less advanced symptoms. We really wanted to tout expert referral. We did the vasoreactivity test, and of course, if it's positive, we go down a different pathway. But if it's negative, we then talk about other therapies, and we grade them. A is the strongest, B is more moderate. And so for the sickest of the sick, epoprostenol got an A, treprostinil got a B, iloprost got a C. For the functional class 3 symptoms, epoprostenol got an A. Beroprost, again, it's not available in the US, but it's available in some areas, got a B. So this is what we were doing for many, many years, way back when we had limited treatment options. The Sixth World Symposium sort of separated that a little bit into, high risk and then low intermediate. So we were starting to look at lower risk patients here. Still, the high risk patients need upfront initial combination therapy that includes a parenteral prostacyclin, whereas the lower intermediate often start on oral PDE5 inhibitors. Now, I want to highlight this paper again from the French group because it really gives the evidence for how strong parenteral prostacyclins can be, in this case, epoprostenol, in that sickest of the sick population. It's just an observational report of 19 patients, really sick patients, 11 functional class 4, 8 functional class 3 with really advanced hemodynamics, a cardiac index of less than 2, and a PVR over 1,000 Wood units. And it really shows the potency of this upfront triple combination therapy. The mean pulmonary artery pressure declines from 66 to mid 40s. The cardiac index goes up from 1.66 to mid 3s, and the PVR goes down from 1,700 dynes to 500 or 600 dynes. So this is a really, really a potent therapy. Now, that was the high-risk population. From the French registry, they've also looked at the patients who are at intermediate risk. And so, again, this is observational registry. These are patients who technically meet high risk. The red is combination therapy that includes a parenteral prostacyclin. The blue is 2 oral therapies or dual combination therapy, and the green is monotherapy. So this is not surprising. In the high-risk patients, these patients on parenteral prostacyclins do really well. But look at this. Even in the intermediate risk patients, the ones treated with a triple combination therapy did better. And that led to this editorial that I wrote with one of my colleagues, Dr. Casino, where we tried to emphasize the orange person thing. We call this the orange people graph, because when we thought about risk prior to that, there's red, yellow, and green. So green is low risk, yellow is intermediate risk, and red is high risk. But what I really think we were starting to appreciate back then is that that intermediate risk falls in a pretty big range. And there are probably intermediate risk patients who really have more high risk characteristics that could benefit from triple therapy, like what was demonstrated in the slide I just showed you on the French registry. So we take that into account a little bit now as we go through the treatment algorithms. And this is the most recent treatment algorithm from the Seventh World Symposium, where we still say high-risk patients need combination triple therapy that includes a parenteral prostacyclin. And not high risk can be treated with dual oral therapy, but there's that little footnote C that really is meant to emphasize that parenteral prostacyclins may be useful in some patients who are not considered high risk, but severe hemodynamics and poor RV function. So the prostacyclins are prominent in that initial therapy for high risk patients and not high risk patients who have some of those features of high risk. And then at that time of the first follow-up, we can think about oral and inhaled prostacyclins in the intermediate low risk population, as well as other options here. In patients who still have intermediate high or high risk, we need to be considering a parenteral prostacyclin. So that's a lot of history of prostacyclins, but things have changed, right? We have a lot of other therapies. And of course, the therapies that many of us are very excited about are the activin signaling inhibitors. The sotatercept data has really been remarkable across a breadth of different pulmonary hypertension populations. I'm showing Zenith here because this is a study specifically in high-risk patients. A large proportion of these patients, about 60%, were on parenteral prostacyclins. And even on top of that, sotatercept has made a huge difference. But even in stellar, 40% were on parenteral prostacyclin therapy. In Hyperion, it was a lower proportion. So Hyperion was the study looking at sotatercept in more recently diagnosed patients. So patients within the first year of diagnosis who were not meeting low risk. So a large proportion of those patients were on dual oral therapy, but some of them, almost 17%, were on parenteral prostacyclins. And sotatercept was really uniformly effective in all of those clinical trials. It's a very effective therapy. So sometimes we say, gosh, with such an effective therapy, a shot that you can give yourself once every 3 weeks, what's the role for parenteral prostacyclins or prostacyclin therapy? And I think it still has a very, very important role. We certainly see patients want to come off of these very complicated pump therapies with the advent of sotatercept. And it's something that we consider very carefully. I always explain to patients that the sotatercept studies, the randomized controlled trials, were not designed to get people off of pumps. They were designed to look at the efficacy of sotatercept in patients already on therapy. So this is a little bit of, gray zone medicine, but, once things are commercially available, we can think about what to do. We can try to use it in different ways. And so we recently reported our experience with weaning off parenteral prostacyclins in patients, in highly selected patients, once we started sotatercept. And this is a very intensive approach that we have. First of all, I can't say that there's been very many patients who are on pumps that don't ask us, can I come off? But we don't say yes to a lot of patients because we really want to make sure they're set up for success. So we recath them, and we only consider this if they're really well managed, if they have minimal symptoms, they're low risk, their hemodynamics have improved. So these are really a select group of patients. And so out of 13 highly selected patients that we tried to wean, we did it successfully in 12 of the 13 patients. One failed and had to go back on IV therapy. Out of the remaining 12, 9 of them we transitioned to a different prostacyclin, so either inhaled or oral. And this is some of the data from that study. If you look at what happens, their mean pulmonary artery pressure maybe inches down a little bit, not significant. Their cardiac output goes down a bit. We know that parenteral prostacyclins really can improve the cardiac output. So it goes down a little bit, but the PVR is about the same. Their hall walk is maintained. We know that their hemoglobin goes up a little bit. Their risk scores are maintained. And this is just a start. These patients, we need to continue to follow and reassess them after they've been off a year or so. So where do we see prostacyclins in 2026? I'm so glad that we have so many additional therapies that we can even have this conversation. Like maybe we don't need to use parenteral prostacyclins as much as we used to. But I think, this is my personal opinion, I think that we still need to use parenteral prostacyclins for patients who are at high risk at the time of diagnosis. There's nothing that works as quickly. There's nothing that gets their cardiac output up like prostacyclins. But maybe for those who are at intermediate high risk, either at, a baseline or follow-up, perhaps parenteral prostacyclin plus sotatercept is an option for those patients. Maybe even some of them we manage with oral and inhaled prostacyclins plus sotatercept in lieu of parenteral therapy if they're not at super high risk. And the combination of oral inhaled prostacyclins and sotatercept may be an option for carefully selected patients who are currently on parenteral prostacyclins. And I think, while everyone's very excited about sotatercept, there are always going to be some patients who don't tolerate any specific therapy because of side effects or AEs. And so there are going to be many patients who still benefit from the prostacyclin pathway if they can't be on sotatercept. But it's still a foundational pathway. It's one of the things that has helped our patients survive longer. It's the longest standing therapy that we have, and I think it still remains important in the PAH treatment. So I think with that, I've left about 15 minutes for discussion and Q&A. So Steve, I'm happy to turn it back over to you. And I'd like to thank everyone for their attention.
Yes, and thank you, Val. Thank you so much. That was great. I'm kind of thinking back to all this. I met you about 20 years ago, kind of at the moment in time when combination therapy was all the rage. And so just kind of like, you pointed out, it's 30 years now in this prostacyclin world. What was it like for you, and your colleagues back in even on those early days before that? What was the kind of the treatment landscape before this even was a thing,
Yeah. So like I said, Steve, I started doing this with Stuart in 1995. And Stuart would say before that, we had digoxin, Aboxaclean-X, and maybe calcium channel blockers for some patients. And so that's what it was like before EPO. And then when I started working with Stuart in 95, remember, all we had was EPO. And so the conversation with a patient was very, very easy. Like they came to us, we made a diagnosis, and we said, this is your option. It's so much different than it is now because we get a patient with a new diagnosis and we're sitting there chatting with them, and we have a dozen medications to talk about and different approaches, including combination oral, including some patients who are still right for parenteral. So it really has evolved dramatically over the past 30 years, and it's been such a privilege to live it.
Yes, indeed. And again, anybody that's listening here, please, I prepped a few questions for Val. She's answered many of the ones that I had kind of set up actually, but put them in the Q&A chat or the chat there. But in the meantime, Val, like, is there like a maybe current or in the Wayback Machine kind of a patient story that you have of someone that was offered this therapy that got on it, and a success story, or just something that's memorable to you over the last you know 20-30 years here of treating patients on IV therapy?
Oh my gosh. I could tell you a bunch of stories. There was a There was a patient, and I think you'll appreciate, Steve. There's a patient that I took care of when I was with Stuart many moons ago. It was the early days. It was when prostacyclin was IV EPO was the only thing that was available, and she was maybe late teens, and she was just convinced, like hell bent on being a normal teenager. And she wanted to do everything. And she was actually featured in a women's magazine, like, in her prom dress with her pump like strapped on her leg. She went on a trip, and I think it was like, end of high school trip to Germany with her German class, and brought all her supplies with her. Like, she was just a really remarkable young lady, and just showed the resilience that it took to function well with that disease. And I'll go all the way from that to one of the patients in um, that series that we weaned off. As she's maybe mid 40s. She's a mother of three. She was so sick when we first met her, has done so well on triple therapy with IV. And this comes out, and she comes to me, and she begs me. She's like, my kids are leaving for college soon. All I want is a couple years off this pump so I could go swimming with them. We could do these activities, like very active family. And we recast her, and her PVR was still around 5. I was a little nervous. I made her no promises, but we weaned her off. We got her off, actually. And she sends me pictures of her jumping off the black rocks into the water with the kids. And she's just happy as a clam. And she knows, and I know, I don't know that this is going to last forever. I mean, it may be that she's back on in a few years, but she's going to get to enjoy experiences with her kids that she couldn't previously. So she's off IV. She's still on inhaled and sotatercept and two orals. But it's just such an exciting time for her.
Here's a question that came in on the chat here. It says, have you seen GLP-1s in combination with sotatercept helping to treat PAH?
Yeah, it is a great question. Like, GLP-1s do a lot of things that we're even still learning about. And certainly, the reduction in inflammation, we think there's some component of inflammation involved in pulmonary hypertension. And we're starting to see them used more and more in our patients, not just on sotatercept, but on any therapy. And what I don't know is how to delineate what is from the GLP-1, what's from inflammation, what is from synergy with another med, and what's from weight loss, right? You weigh less, your hall walk is better. So, we've certainly seen some patients on it, and some patients feel better on them, but I don't know what exactly the mechanism is. And it's really interesting because we're starting to talk about this in clinical trials, right? Because hall walk is the primary endpoint for a lot of clinical trials. And so if a patient's on a GLP-1 and their hall walk gets better, is it because of the GLP-1? Is it because of the drug? What if they're on placebo and they look better? So we're going to have to kind of figure out how to manage this as we continue to do research.
How about what is, whether it be trials, I want to ask you about misconceptions. Like, what is the biggest misconception, do you think, on prostacyclin therapy that you wish more clinicians or even patients and their caregivers would kind of leave behind?
Yeah, it's a great question. So I think one of the big misconceptions is it's you save it to the very end, right? Like, there are, I grew up with it, right? I've been used to using it for a long time. There are a lot of people who are treating pulmonary hypertension now who have lived in the oral era where they've used very little prostacyclin, and so they're not as comfortable with it, or you think it's really just for end stage disease. And it's really not. I mean, there are patients that are, short of end stage that could benefit from them. Advanced hemodynamics, bad RV function, where I think we need to consider being more aggressive with them at the beginning, knowing that maybe there'll be the option to peel back. So that it's something just for the last option is, something I would like to rewrite the script on. And of course, there's never been a patient, actually, well, maybe one I can think of, but besides her, there's never been a patient who's come to me and says, please, I want to go on the pump, right? Like, patients don't want that. We get that. But we need to make sure that they understand when it's a good option for them, or at least keep their mind open to it. There are plenty of patients that I see when they're first diagnosed, if they're at intermediate high risk, I know I'm a little worried about them. I introduce a pump to them, and I know they're going to want dual oral therapy, but I introduce it at the beginning to say, happy to try this. We need to watch you closely. But if you don't perk up, we might need to consider the pump. You kind of have to start demystifying it early in the course of the disease.
How about, what lesson or lessons from this prostacyclin story do you think should inspire the development of the next generation of therapies, or the next way clinical trials are being written or planned?
Oh wow, there are so much that we've learned from the prostacyclin trials, be it the hemodynamics, the outcomes. I think one thing that we've learned, been pretty clearly demonstrated, is about dosing. Like, we need to make sure we understand the right dose of a drug as we go into a phase 3 trial, because that's where we're going to have the most success. So some of the studies that I showed you, particularly with treprostinil, there's a dose response, right? And we didn't really understand that fully during the trials. And some of those trial results could have been even better if the patients had been dosed up a little bit higher. So dosing, I think, is a really important thing. And side effect management, right? All of the prostacyclins have side effects. Like, every drug has side effects. But all of the prostacyclins have kind of similar side effects. So helping to manage those to mitigate the side effects and reduce discontinuations from drugs, I think, is something that we've learned from the trials.
Here's another question that popped in. Some patients do very well on 6-minute walk tests because they are high functioning, yet they have severe PAH and they are always left off clinical trials because of their walk scores. Is there any discussion, perhaps at this World Symposiums, about how to better serve those patients in a way for them to enter clinical trials?
Yeah, that's a great question, and it's an issue that's near and dear to my heart. Because you'll hear me all the time talk about the limitations of risk scores and risk assessment, and it's been great research, and I'm appreciative for all of it. But that's a population that it misses: the young person who scores low risk because they walk 450 or 500. They're in low risk category. They could function well, but their RVs are bad, their hemos are bad. So it's a tough question, though, because when you look at primary endpoints of trials, sometimes you have that ceiling effect. You can't walk further, and so they're worried that that's going to dilute the effect. I've lobbied to have more liberal hall walk cutoffs, particularly in the phase 2 trials when you're looking at PVR, because a young person who overwalks, they walk 600 but has a PVR of 10 is really still a good patient for that sort of a trial.
Here's one more for you. Actually, two. Okay. One says, how do you decide whether to proceed with oral prostacyclin versus sotatercept as a third line?
I'm sorry, I'm smiling. I just see that message from Carl. Carl,
Yeah.
it's nice to see you. I hope you're well. Okay, oral prostacyclin versus sotatercept is third line. Great question. There's clearly not a comparative study. And I would even say it's not just oral, it's oral or inhaled prostacyclin as third line. So you have a patient on dual oral therapy. They're not where you want them. Either they're not meeting low risk, or maybe they meet low risk and they're like the patient we just talked about. They're young, they function well, they technically meet low risk, but they've got a bad RV or they've got advanced hemodynamics. There's no comparative data between oral / inhaled prostacyclin and sotatercept. You can look at individual data. I think the individual data for sotatercept is very, very rich, right? You've got Stellar that would include that population, and you've got Hyperion that would include that population. Zenith is a sicker population. And those two studies are very solid in terms of improvements in functional capacity. Stellar included hemodynamics. They both included endpoints. But you also have to balance that against the side effects of sotatercept that include the increase in hemoglobin, reduction in platelet count, some of the things that we're seeing commercially, the pericardial effusions, the shunts. So you kind of have to present that to the patients. And then the oral inhaled prostacyclins, maybe there's a little less data on them. There's certainly a little less data on combination with both ERA and PDE5. Some very strong results as well, but not as many not as many trials with multiple endpoints as sotatercept, but has the side effects that we all know of prostacyclins: headache, flushing, heartburn, jaw pain. So what I do is I present both of the options to the patient, and I've had some patients say, you know what, talk to me about sotatercept after it's been around for 20 years. I want to stick with the thing that has been around. We know the long-term safety profile. I've had other patients say, I've heard remarkable things about sotatercept. Let me try that before I try inhaled oral. And then there's individual patient factors you need to take into account. I think the bleeding is a big thing. If a patient has a bleeding risk, I tend to go more towards oral inhaled prostacyclins. But it's the classic shared decision making, right? Every patient's different, and you just need to go through that data and look at the specifics of that patient and help come to a decision.
Well, I think we're almost out of time. I do want to take a moment, though, to let you tell people about an upcoming symposium that you're presenting in early October. I know you're on the steering committee, if not the chair of this committee for World Symposium. I'll let you tell us a little bit about that.
Yeah, so the World Symposium on pulmonary hypertension, which happens about every 5 years, we are, they're almost always in Europe, right? And that's really mostly a cost thing, to be honest with you. The only one that's ever been in the US is Dana Point in 2008. So I really wanted to have a meeting in between the World Symposium. The next one will be in summer of 2029, to really talk about the critical things, some of the questions like you guys asked, some of the topics that might be very relevant to the next World Symposium, and give the US audience an opportunity to kind of reflect and tell us what they think is important. So we're doing a CME event here in Ann Arbor on October 2nd. It's a great CME lineup of very relevant topics, but also there's time to get feedback for what the investigators, what the healthcare providers want to hear discussed at the next World Symposium. So that is October 2nd at the Sheraton here in Ann Arbor.
Well, wonderful. That's really a testament to the work, not just of you, but all your colleagues over these last 30 years. I can't thank you enough for your presentation, Val. So I do want to say to anybody listening, though, if I could take a moment to share my screen. We have more of these webinars coming up. The next one is on Monday, August 17th, with Dr. Sandeep Sahai, Combination Therapy, Redefining PAH Treatment Strategies. The Future of PAH, Emerging Targets and Therapies with Dr. Stephen Chang, and also Global Centers of Excellence Collaboration in Care with Dr. Benicio de Jesus Perez on August 26th. And finally, one for Clinical Trials Matter, the Backbone of Innovation with Dr. Gene Elwing. That one is on September 15th. You can go to phaware.global/webinars. And let me close on this for 1 second, and I'll stop sharing and just say that I will have we will post this webinar momentarily in a few days, and it'll be also available on our HeartWorks app and PH Aware social stream. So, Val, thank you so much again for attending. I appreciate it.
My pleasure. Thanks, Steve.
All right, we'll see you next time, folks.
All right. Bye-bye.